Hello, everybody. This is the Global Liver Institute's International NASH Day presentation, Patient and Provider Perspectives. I am Donna Cryer, the founder and CEO of the Global Liver Institute, which is a patient-driven advocacy organization headquartered in Washington, D.C., and we are so excited to be with you and with everybody in 22 countries around the world who are doing international NASH awareness events today, and to talk with our fabulous guest, Dr. Nadege Gunn, who is a gastroenterologist, a hepatologist, which is a liver specialist, out of Austin, Texas, and the Pinnacle Research Group, and Kim Martinez, who is a NASH patient advocate, a graduate of our Global Liver Institute Advanced Advocacy Academy from Broken Arrow, Oklahoma. Welcome to everybody, and welcome to everybody who is viewing us. So, Dr. Gunn, what is NASH and why should we care about it?
Well, NASH is a chronic progressive liver disease, and it's characterized by the accumulation of fat in the liver cells. And the liver does not like fat, and fat creates a toxic environment to the liver. And as a result of such, the fat causes inflammation, severe irritation to the liver, which can then cause scarring. And that scarring over time can progress to cirrhosis. And cirrhosis is really the bad name in this, because that could then cause liver failure, liver cancer, death, and of course we want to prevent that outcome.
Most people think that cirrhosis is only caused by excessive alcohol use, so that is not the case.
That is not the case, and that's been a common misnomer. People can develop cirrhosis from a number of liver diseases, and fatty liver is one of them, and it's kind of unfortunate because these patients oftentimes are not doing anything where they're exhibiting some dependency on a drug. They just are living life, eating tortillas, enjoying life, and then they find that they develop diabetes, high blood pressure, high cholesterol, and then that oftentimes links to fatty liver disease.
And so NASH is the more advanced form of fatty liver disease. It's really sort of a spectrum of the disease. Okay.
Absolutely.
And Kim, unfortunately, you had that advanced stage of fatty liver disease, NASH. What does it mean to be a NASH patient?
Well, in my case, it was a complete surprise. I was eating healthy. I was swimming laps every day. I was doing Zumba. And one day I woke up with what I thought was a flu. And later in the evening, I threw up a large amount of blood, about a quart blood. Ended up in the ER where they proceeded to tell me that I had cirrhosis. And I just couldn't believe it because I'm not a drinker and I never have been. And so it started off as a complete surprise. I was shocked. And then I started having other symptoms. I was retaining fluid in my stomach. I eventually got to the point where I was sleeping all day and I'm staying awake all night. And it was just miserable, and I had no clue anything was going on with me. I had no idea that I could even get liver disease. So it was just shocking to me.
Wow. Dr. Gunn, you are you're at the forefront of trying to find a treatment for NASH. What are your challenges in finding that treatment?
So we certainly at Pinnacle are trying to be in the front of this disease, and I have a world-class organization looking at different medications, different small molecules to find a cure. But the challenges are, number one, that this is a very under-recognized, underdiagnosed disease. And how can you find a treatment for something that people don't know exists? Right. And then secondly, as we alluded to earlier, fatty liver, the umbrella fatty liver, there's simple steatosis, which is simple fat in the liver, and then you have NASH, which is the aggressive form. And currently today, the only way to distinguish the two is with a liver biopsy. Wow. And a liver biopsy is, as it sounds, potentially painful. It's not without complication. You can cause perforation to nearby organs, bleeding, etc. So that shies a lot of patients away from wanting to know whether they have NASH.
Absolutely. I've had 6 of them, and I wouldn't want to have another one, surely. Why don't we have better technology today? Why are we still using liver biopsy? I think of doctors in Star Trek saying that's barbaric. Why are we still doing that?
Well, it's because we still need, we always say tissue is the issue. You have to look at the liver on a microscopic level to really know what's going on, but not to take anything away from non-invasive technology. And that's what research is bringing to the forefront, is finding ways to take simple blood tests that a primary care provider would get on any patient and plug them into these algorithms that give you a sense of how severe the fatty liver can appear. Several wet biomarkers is what we call them, these lab tests, such as the ELF test, the NAFL fibrosis score, the FIB4. There's several that we're using in clinical trials. And we also have some non-invasive imaging modalities. One is called the FibroScan, the other is a multi-parametric MRI, where you can assess the amount of fat in the liver and also the stiffness. How hard is the liver? Is it soft and spongy, or is it hard as a rock? So we're getting there, but we still need to validate these things.
Okay, I look forward to that day. Kim, have you had to undergo a liver biopsy?
Yes, I've had 3 of them.
Wow.
Yeah.
And what was that experience like for people who haven't had them? Like, what do you do, and how long does it take? And
they take you into a room, and in my case, they gave me some sedation, and they put a long needle in your liver, and you hear a little click. And then afterwards, they take you down to recovery, and you have to lay on your side, in my case, like 4 hours, to make sure that there's no bleeding. And there's a chance they can miss the spot, and they can cause more bleeding. They can cause more damage than just a biopsy. But in my case, all 3 were successful, and they are uncomfortable, and one was painful. But yes, they need something besides a liver biopsy.
so we have an entire campaign at the Global Liver Institute called Beyond the Biopsy, and not to get beyond the science, but to nudge it along, because I look forward to the day when your clinical trials are successful, and we do have a treatment for NASH, hopefully in the next 12 to 18 months.
Right.
And I would hate to think that millions of people would need to have liver biopsies to be able to benefit from that treatment.
Right.
So, what is the forecast of the landscape for those liver treatments, liver therapies? What would things look like sort of 18 months from now, when we do have one or more drugs? What would they do? How do they work?
I think it's going to be very complicated. We have to figure out who would be priority to treat. Probably we might see some payers giving us a little bit of pushback as to deciding maybe the patients who have more advanced disease should be treated first. NASH is very much like diabetes. Sometimes no single one medication really brings that patient in control. So I'm thinking, and many of the researchers and key opinion leaders in the field think, and I think they would agree, that we'll probably need multiple medications to hit different targets in the inflammatory and scarring cascade that's occurring in the liver.
Right. So you mentioned a really important point that I want to come back to. So you think that perhaps payers or health insurance companies might require, as they did in the early days of hepatitis C, that patients have very advanced disease before they may allow treatment, so they'd wait until people needed a transplant like Kim or I needed to be treated. Can there be a place where there's a sort of a solution for every stage? So if you're in early stage of fatty liver disease, then maybe it's paying for intensive diet and exercise or behavioral support or health coaching. At early stages, there may be some drugs that are effective in those early stages of fibrosis, and then some for the more advanced and those with cirrhosis and late stage. Would that be a better way for the health insurance companies to think about it?
Absolutely. I think that we're definitely going to need a focus on prevention here. Maybe the payers will find that those who are more or less advanced can really benefit from aggressive exercise, aggressive dietary modification, and then as patients are discovered to be more advanced, that's when we implement the big guns like the anti-scar fibrotic medications. So there'll be a landscape there and an algorithm that will be at the hands of either hepatologists, endocrinologists, or other people that would see a multitude of these patients.
Great. Kim, you were already doing so many things right. You were eating right, you were swimming, you were doing Zumba. I want to become a Zumba instructor someday. That's my hashtag.
It's so much fun.
And so, what did your journey start? How were you diagnosed, and what were the steps that your healthcare system took you
Well,
through?
I wanted to be a living kidney donor for my brother, and so that's one of my motivations, becoming a new healthier me. And one day I got sick, and I ended up in the emergency room after having thrown up some blood. And when I was there, first thing they asked me was, "Are you sure you threw up blood?" And I looked at my brother, and I said, "I did, didn't I?" And he said, "Yes, only about a quart." And the nurse said, "Well, let's find out." And she put an NG tube down my nose, and up came bright red blood.
Wow.
So from that first interaction, I got the feeling anything I told them, they didn't believe me. And I didn't think cirrhosis was possible unless you were a drinker. And so when they asked me questions about drinking and drug use and other things, and I told them, no, I never had been, I got the feeling they didn't believe me. So from the get-go, I didn't have any trust in them, and I felt like they didn't have any trust in me. So that's one thing I would change, is I would wish that they would believe the patient. And it was Christmas Eve that night, and my sister, who was a retired nurse, said, well, they don't believe anybody, especially Christmas Eve. They got you on a bender. And so that's how I was diagnosed, and at the time they didn't even tell me it was NASH. They didn't tell me they thought it was NASH. I just assumed they thought I was a drinker. So the first time I ever knew that I had NASH was when I read it on my discharge papers.
Wow.
From the hospital. And my information came straight from the internet.
Wow.
And I had a month between that, going home from the hospital, and my follow-up, and that whole month I thought I was going to die. And so I wished no other patient would go through that. I wish that they would give them education, and they would let them know, even if they already have cirrhosis, let them know that there is a way you can get a transplant. So that's one of the things I would change.
Okay. I'm going to give you a moment there. Thank you so
Thank
much
you.
for sharing your story.
Thank you.
So the Global Liver Institute has convened a NASH council of different medical societies, including the liver, gastroenterology, but also endocrinologists, primary care, nursing organizations. How should we, Dr. Gunn, how should we help physicians and hospital systems, better respond to this, better recognize this, so patients like Kim don't face having to find out passively on their discharge papers that they had NASH, but there's a more proactive approach and conversation coming from the medical side. Certainly, in hepatology, you all are on it. You know about this. The liver is your thing. How do we help the other types of doctors really work with this?
This is going to be a multidisciplinary approach. We know that patients who are obese have maybe 90% chance of having fatty liver disease. Those who have high cholesterol, 50%. Those who have diabetes, 60%. So we have to just look at the patient. When the patient walks in the door, if they're carrying a little extra weight, maybe take an extra step and get a couple of lab tests to see if the liver is looking okay. Maybe do an imaging test, maybe an ultrasound to start to see if there's fat in the liver. That is where we start. Then we can dive down and then see if they're at risk for advanced disease like NASH or fibrosis down the line. But I think it's going to start with primary care awareness, recognizing the risk factors and maybe screening those patients in very inexpensive ways.
And what are some of those inexpensive ways? You name some algorithms, for example. Can patients themselves, if they have their lab work, can they go online and calculate their own NAFLD score and things?
They actually can, but I will say they should do that with caution. So they can take a series of liver enzymes, for instance, and their age and their body mass index or platelet count, and they can plug it into, say, the NAFLD fibrosis score calculator. And it will give them a range that would put them either high risk for having fibrosis or scar, intermediate risk or low risk. And maybe they can take that information to their primary care.
Does that help them have the conversation with their doctor and maybe
absolutely.
some alerts? I know, I wear, a wearable on each wrist. And so I try to have the conversations that I have with my multitude of specialists now to be more data informed.
Right.
And so I think that, rather than just trying to do random internet searches, but being able to provide people with the right resources that may just help sort of guide the conversation with your physicians in the right way.
Especially in this day and age where people have access to so much information.
Right.
Doctors better beware that patients are coming in armed with information, and you'll need to be able to process that and help them through.
So Kim, what has helped you now? What does your life look like now?
I'm doing absolutely great.
That's
I
great
love my life. Every morning I wake up and I can't believe I'm not only still here, but how happy I am. I still go to the pool. I play volleyball. In fact, we play water volleyball twice a week. And I still swim. And I still do Zumba. I want to say hi to all my Zumba girls. And I volunteer with Life Share of Oklahoma, which is an organization that spreads organ donation awareness. And I'm hoping to attend the transplant games next year in New Jersey.
I think that's fantastic.
Yeah.
We have one of the other A3 or Advanced Advocacy Academy alums who has won a gold medal in the transplant games, and then they've tried to recruit me, and I was like, I was not a fantastic athlete before multi-organ system failure, so I'm not quite sure what a few knees ago, but I'm inspired, and so you may have convinced me that maybe now.
Oh, you should.
Now is the time. I'm not sure. Maybe I'll play pickleball. There should be some sport.
Oh yeah, they have all kinds of sports. You should go online and look. Yeah.
Fantastic. Do we have questions off of Facebook, or should we keep this wonderful conversation going? Okay, fantastic. So tell us about Texas, Dr. Gunn. My understanding is in the U.S. it's sort of an epicenter for fatty liver disease and NASH, and why would that be the case?
Well, it's the tortilla capital of the world. But Texas is great, and everything is bigger in Texas. and so I think we really stand by that in multiple ways. But I think, though, just having been in Texas and treating patients in Texas, that they're just a great group of folks, and they're very committed and doing research. All of the patients want to be at the forefront of finding a cure for this disease, so they're very excited, they're very motivated. And it's funny when a trial is over and you tell, hey, Mr. Garcia, I'm sorry, the trial has ended, we're done here. They're like, what? I can't believe I need something else. So they're very excited, and I'm happy to be there because I know we're going to find this cure, especially if we continue to have the patients that we do.
Is there a particular gene or genetic risk factor that makes Hispanic populations or people with Hispanic descent more predisposed to fatty liver disease?
Well, there is a gene, and there's several genes actually, but one that comes to mind is the PNPLA3 gene, which we find to be prevalent in those populations and those who have a strong family history of liver disease and cirrhosis. So through research, we're trying to uncover that link, of course, to see if there's something that can be done there. I
heard that maybe close to 53% of the fatty liver-related deaths will be from people from Hispanic descent. Is that the case?
That's about the case, right? We're finding that the number one cause or reason for liver transplantation is soon to be fatty liver, if not already. And especially in women, it's fatty liver disease that's causing transplantations like Kim. So we need to do something.
And so it seemed like, hold on just a second. Pregnant women. So I've heard about gestational diabetes. Should women mind their sort of weight and think about their liver disease or creating a liver disease or passing liver disease or fatty liver disease to their infants and children? Should women be concerned about that in that regard as well?
I think in general we just need to adopt more of a preventative lifestyle because we know that there's not one single thing that causes fatty liver disease. There's a constellation of things. So just taking it back we need to eat better. We need to incorporate exercise into our daily routine. And so then we are then mitigating the development of fatty liver, development of diabetes, high blood pressure, high cholesterol, and so forth. So I think that should be the general conversation.
Okay. I would like to see NASH better integrated into, I know NIH has a gestational diabetes program. I'd love to see NASH there. There's research on childhood liver diseases. I'd love to see NASH research, there. Are there other areas that, we could see that even existing research could better include liver health aspects and NASH-related aspects, do you think?
I think that just following along with the metabolic syndrome, so we can almost go into every organ system, say nephrology, for instance, and kidney disease. These patients oftentimes are diabetic. Oftentimes they're obese or overweight. That would be an area where we can focus NASH trials. In the endocrinology section, diabetes, lipids or cholesterol, that's another group. So it's not all under the hepatology or liver umbrella, it's multidisciplinary.
Right. So we're everybody's patients.
Everybody's patient.
Frankly.
Right.
Can I have that question again? Kim, what do you tell your family and your community about this?
Well, I kind of throw the word NASH in, and sometimes they look at me like, what's that? And then I say, well, you really should know about it. And I tell them about fatty liver, how it can progress to being cirrhosis. And I've often wanted to ask, I'll ask you, you know how when someone is told they're pre-diabetic, can you tell someone who has fatty liver that they may be in danger of being cirrhosis later? So can you say they're pre-cirrhotic? Is there such a term? And if there is, shouldn't they use that instead of saying fatty liver? Because fatty liver is now you hear it all the time, and it's not taken seriously.
Right. So that goes along with either the non-invasive markers or the liver biopsy. So in order for us to tell someone they're pre-cirrhotic, and let me just segue to this a little bit better. There are 4 stages or 5 stages of fibrosis, of scarring. So there's stage 0, where you see no scar at all. 1, 2, 3, and 4 is cirrhosis.
Okay.
So oftentimes, and especially in my practice, if I have a patient that's stage 3, that's pre-cirrhosis in my mind. And the patient ought to know that I'm going to be more aggressive with managing them. I'm going to be looking for liver cancer and other risk factors for ultimately their liver not working. And so to your question, yes, so that would be the biopsy to help the patient know, hey, this is not just a simple fatty liver. You have a lot of scar. You are on the line to cirrhosis. Or those non-invasive testing like the FibroScan, which gives a little vibration, a little pulse of vibration across the liver and tells us how stiff the liver is. That's a good tool to use for those who may be a little bit reluctant to biopsy. If that number is high, if it's abnormal, that would be someone that we would take to biopsy to see if there really is advanced disease.
Kim, you and I are getting a lot of transplant love from the Facebook community, so thank you, and love right back to all of our fellow transplant survivors. It's amazing. This is the 25th anniversary of my transplant.
Wow.
And so it's
Today is?
Well, this year.
Wow.
Well, so we get to celebrate. At this point, I get to celebrate all year long.
That's awesome.
And so other comments from Facebook community are, just to go over again what people need to be telling their doctors, that conversation that they need to be having. So I'll let the doctor start for once.
So if you think you may be at risk, say you've been a little bit overweight your life, maybe your doctors are tossing around the pre-diabetes terminology to you, or that they are a little concerned about your hemoglobin A1C being on the line, then ask your doctor, hey, is my liver an issue? And maybe that will segue the conversation to looking at a little bit closer testing with labs or imaging.
I think that's a great way to start, even for people who aren't really, I don't want to be aggressive with my doctor, or I don't want to come in like I know everything. Just asking the question, should we be thinking about my liver, as part of this, treatment plan? I think is such a great way to start. I've been thinking about sort of ways to convey this, and I've started thinking about sort of 3 C's, conversation, coffee, and clinical trials. So, the conversation can be about, do I have these risk factors? Should I be tested? What does that testing, look like? And then also, what support is available? Because all of the successful patients, for the most part, that I've talked to, who've achieved that, 7-10% weight loss that is necessary to achieve and be sustained to really affect their fatty liver disease or NASH, they've had some type of support, some health coaching or dietitian, or even if you've been working on your weight for 20 years, some type of behavioral support or psychologist or something. There shouldn't be no stigma around that to help you get such an important impact. So, and often there's insurance either that's provided in your clinic increasingly, or your insurance will reimburse for that, and most people don't know that type of support is available. So having that conversation around testing and support, and then after so many dire conversations about what you can't do and scary things, I'm like, well, if you're drinking your morning coffee, that's good for you.
Coffee is excellent for the liver. Yes.
And then finally, clinical trials. Right now, without an FDA-approved treatment ready, participating in a clinical trial could be the best type of treatment that you can get right now.
Absolutely. Yeah.
So how many clinical trials are there going on right now, and how many patients are involved? It's a pretty robust enterprise.
It is. It's a very competitive landscape in fatty liver research. There could be anywhere between 75 to 100 trials ongoing. As you know, phase 2 is where the most of the studies are. So that's looking at not only is the drug safe, is it effective, and also just looking at some of the non-invasive markers there, and then they move on in the phase 2A to the phase 2B. Most of the studies are in that place. We only have a handful of drugs in the phase 3 platform on the brink of potentially being approved, about 4 that come to mind for me. So we still have a ways to go, but there are a lot of stakeholders looking for that drug.
And even after a drug is approved, or one or more drugs is approved, we're going to need to be doing research and studying, working with patients to study the disease, to look at outcomes research, for some time.
Right. Absolutely. Because if the drug makes a change in the liver histology, for instance, that matters nothing if it's not changing outcomes. Do we save lives? Do we decrease liver cancer, liver transplantation, liver failure? We need to know that. So as these drugs are in the phase 3, they have these long-term extension arms where we are looking at outcomes, because that's really what matters.
Right. Now, does family history play into this? Does NASH run in families?
Well, I would have to say it can, especially since now we're realizing that there are some genetic associations with fatty liver disease. I have several patients in my very own practice that have had 3 generations of cirrhosis. And to be really honest, these patients are just normal, healthy appearing human beings who are in their late 30s, early 40s with cirrhosis. So there's a genetic link there, and we need to be able to recognize it and be aggressive, especially in those families.
Sure. And we do see, lean NASH in particular, so people having NASH at lower body weights, lower BMIs, particularly in Japan and Korea and in areas of Asia, even here in the US, but in many different parts of the world in greater prevalence. Is that true?
And that phenomenon, we believe, has a lot to do with what we call visceral adiposity. So the fat that cakes the organs, the fat you can't see, is what is affecting the liver adversely in those instances. And that's being studied very much as well. But right now we're just taking what we have, which is that obese NASH with the multiple risk factors.
There's also sort of a family environment effect, isn't there? So if, everybody is eating fatty foods, if that's what's served at dinner on your dinner table, if everybody, if you all stop in the car at McDonald's on the way home or some fast food restaurant, then you're more likely all to have. So if you get a diagnosis of fatty liver disease and NASH, you should probably talk to your family about potentially getting tested or seeing if that sort of environmental contagion, if you will, is part of your family history. So can medications cause liver disease?
Well, yes. So fatty liver, again, is an umbrella term, and when we say NASH, we're calling it non-alcoholic fatty liver. But medications, if you want to call alcohol a medication, that can cause fatty liver. Medications like methotrexate can also cause fatty liver. There are other medications, some seizure drugs, for instance, can cause a fatty liver. So there are a lot of medications. So again, we don't want to just apply the term too loosely. You do want to see your doctor and have all those things assessed. But in this particular conversation is the non-alcoholic fatty liver disease. But yes, medications can lead to a fatty liver.
I think for liver health in general, people don't appreciate how excessive doses of Tylenol, for example, particularly if you're taking it in pill form and in cold medicine or something, can have toxic effects on the liver. People who are looking for information on fatty liver disease and NASH often find milk thistle this and all sorts of supplements that may have dangerous or adulterated ingredients in them that can be harmful. And also if you have a advanced liver disease, or particularly if you have decompensated liver disease, then even medications that maybe you might have handled well before may affect your liver.
Absolutely. So as a liver specialist, we do have to spend some time with our patients, especially if they have liver disease, to tell them, please talk to your doctor before you take anything. So for instance, Tylenol, as you mentioned, the average person who doesn't have liver disease can potentially handle 4 grams of Tylenol a day. But in a cirrhotic patient or someone with advanced liver disease, that's only 2 grams that they can handle a day. So it's not that they can't take Tylenol, it's that their body's just not going to process the Tylenol as well as someone whose liver functions normally. So again, take-home message, please talk to your doctor before attempting any over-the-counter herbal or medication.
Absolutely.
Especially in the setting of liver disease.
So for the folks just tuning in now on Facebook worldwide, I am Donna Cryer, CEO of the Global Liver Institute, and I'm here with Dr. Nadege Gunn from Austin, Texas, Pinnacle Research, and Kim Martinez, a NASH patient from Broken Arrow, Oklahoma. And we have been talking about fatty liver disease and NASH, which affects 115 million people worldwide. Oftentimes I get asked, why have people not heard about this before? Oh my goodness, it's so serious. There's so many people affected. Why are we just starting the conversation today?
I think it's just been under-recognized, and we didn't know back then that it could lead to such dire complications. And so I've had patients say that they were just going in for a gallbladder removal for some stones, and it was identified that they had cirrhosis or something, just unsuspecting, like you going to help your brother with the transplant, and you identify it. I think now we just need to do a better job of raising awareness, because this is a real disease and it has real bad outcomes if we don't intervene.
And so that's why we're recognizing International NASH Day today with 60 partners in 22 countries. We've been so excited about that. The events range from documentary films that have been created by NASH patients that are premiering today. People are being very creative. It's really exciting. There are embassies. The Mexican consulate in Texas is holding events with our friend Wayne Eskridge from the Fatty Liver Foundation, who's also a GLI A3 graduate. We've produced materials now in 8 languages, which has been so exciting for us to be able to meet that need. And so we hope that this is the start of a global movement, that today we'll be diagnosing people appropriately, intentionally, not by accident or when they're looking for something else. So one of our viewers, Hillary, had a transplant in 2017, and her only symptom was Kim, like you, like vomiting the blood. So Dr. Gunn, what causes that vomiting the blood? So dramatic. So
it is dramatic, and Kimberly, what's
Hillary.
Hillary and Kim presented with just vomiting blood, which is very catastrophic and dangerous. And I'm so happy that you will survive something so serious. But what happens in the liver is the liver gets severely scarred down. So the liver sits right here, and it gets so scarred down that it...
Point that out to people again.
So
it's right here.
It's
Let's everybody right here, not back here. That's your kidney. It's right here,
right under your ribs.
It's the right upper quadrant, and blood flow from the intestine has to make its way into the liver, out of the liver, into the heart, and to complete that circuit. So when the liver is hard as a rock, and the blood is trying to make its way through, it hits resistance.
Right.
And so now the blood is going up blood vessels, especially in the esophagus, which we call varices. Those blood walls or those veins get so engorged and they become very, very thin, and eventually they rupture. And then that's what leads to the vomiting of blood. And oftentimes that could be fatal. And the way we go in is we take a camera, we go down the esophagus, and we tie them with rubber bands to collapse them. And I know that Kim had that done. And sometimes we also do a procedure called a TIPS, where we bypass the flow of blood the way that I showed you, so that it doesn't cause all the pressure behind those veins.
Right.
But yes, it can just present with a bad bleeding event, like in Hillary's case. Thanks for your question, Hillary.
Yes, and I hope you're doing well. So Kathy contracted hepatitis C from a nail salon. Can that lead to NASH? So there are two different types of liver disease. So, but tell us more.
So two different liver diseases, but they can coexist in the same person. So hepatitis C is a virus that you can contract through blood, sex fluids, et cetera, blood transfusions, IV drug use, et cetera, tattoos. And fatty liver is, as we talked about, a metabolic phenomenon, diabetes, obesity, et cetera. So you can have hepatitis C and NASH at the same time, but hepatitis C, fortunately, is a treatable disease. We have medications that can cure it, get rid of that, but you may still be left with the NASH piece. And of course, the lifestyle changes are really important. That's the key to treating this disease. And of course, if you're not successful there, then potentially a clinical trial until we have something FDA approved to treat it.
So a moment for manicure advice. So you don't have to give up your fashion or your manicures to have liver health. Just ask them not to cut your cuticles, which is what I assume perhaps to happen there, but just push them back. And you can still look glamorous and stay healthy.
Right.
So, that moment aside. Keep the questions coming. So, and I think that that is important. So, Kim, how long ago was your liver transplant?
It was February 11th, 2016.
Yes. So
3 years and 2.5 months.
And counting.
Wow.
Yes.
And counting. But you look wonderful, and
Well,
you keep yourself in shape. And I know I had to. So many people, when I say I've had a liver transplant, they'll go along and be like 30 seconds in the conversation, they're like, wait, you? And so I think that the perception people have of liver patients or liver transplant recipients is that, that we're still, sick, and that, we may be in wheelchairs or, or sort of leading half lives, but it really is a miracle and an innovation. Too few people, get it. 22 people die on the list every day waiting for a transplant. Right. There are 15,000 people, I believe, on the list at this point, but only 7,000.
Very low.
Transplants, liver transplants are done every year. Right. So we need to both prevent people from needing transplants would be the first thing, but also people need to donate and express that you can express that actually on Facebook, because thanks Facebook for allowing you to indicate your donation wishes on Facebook and on social media. Cheers to the group Organize, which is the advocacy organization that worked with Facebook to make that happen. And talk to your family about it, because their family will ultimately be in the position, unless you do a living donor, as you were trying to do, your family will make that decision for you. So we need more organ donors so that folks can go on to live wonderful, healthy, full lives, and go back to families and jobs and build organizations and do all of those wonderful things that transplant survivors are able to do. But we don't want people to need them.
Right, right. So it's prevention for sure.
So we're going down to Capitol Hill later on today, and we're going to be joining some other fantastic doctors, not only fellow gastroenterologists and hepatologists, but endocrinologists as well, to your point about making connections with those who are providing diabetes care. And so, give people, who won't be joining us on Capitol Hill a little preview of, what you want policymakers to know about this. What can they do to help?
Well, I am a United States Air Force veteran,
Oh my goodness.
and I have seen first and foremost how federal funding can make such an impact on research and development in liver disease, such as hepatitis C, for instance. So I just want them to know what a tremendous impact they've already made in liver disease, and they can continue to make if they just kind of switch it over to NASH now, because they are phenomenal, and they probably need to understand, of course, the burden of the disease, the fact that it's under-recognized, underdiagnosed, so we have to make an effort to inform our primary care and endocrinology and nephrology colleagues that there's something that they may be seeing in their day-to-day practices that they can help us uncover. And then if they can bring those patients over to trials so we can find the cure, then I hope that message resonates with the policymakers.
Dr. Gunn, that's an excellent point. You know, the VA really does have an unprecedented amount of not only of viral hepatitis, and they made such an incredible decision to eliminate it, and were given the funds to do so. And there are high rates of liver cancer, and I'm presuming NASH. And so you're right. If Congress can make sure that they have the resources to be able to treat our veterans, to be able to manage and treat and cure all of their liver diseases and avoid liver cancer and the need for transplantation, I think that's a great place to start.
It sure is. And I'm so impressed with the Veteran Healthcare Administration. They just passed the Mission Act that allows veterans to get health care even if it's not in their local VA hospital. So we do know federal funding has a huge impact. It did in hepatitis C, and I hope so that will translate into NASH.
So we've had some additional viewer questions, and I thought maybe we talk about the relationship between liver disease and IBD and colon cancer, because they sort of go hand in hand. They're all parts of the digestive tract that people don't realize, and sometimes bleeding in the colon or other areas may lead to findings of liver disease. So talk about the relationships between the rest of the digestive tract and liver disease.
Well, they're all separate entities, of course. Your colon cancer, inflammatory bowel disease, which usually falls under Crohn's and ulcerative colitis, and of course there's liver disease. But that doesn't mean they all can't interplay in the same patient. So while you're doing that colonoscopy and you see big blood vessels or something, or a very patchy appearance of the colon, you might think, is there something else going on beyond the colon? Patients with inflammatory bowel disease, as you may also know, may be at risk for other liver diseases like primary sclerosing cholangitis, and that's a liver disease that interplays with inflammatory bowel disease. So they do have some connections, and not to say that you can't have a Crohn's patient who also has NASH. So I think we have a difficult task in not only treating a patient as one disease set. We have to look at the entire GI system and ensure we're capturing everything that's going on.
Well, that was certainly my experience, and clearly the experience of one of our viewers as well. So I had inflammatory bowel disease, and it did develop into liver disease and was the cause of the need for my transplant. So hearing that message to all of my physicians to sort of look at all the pieces that they fit together and reside in this same body, is an important message. So for a NASH patient, how many doctors are they likely to see? Are they all sitting with you, the hepatologist, or probably not? Maybe there aren't enough hepatologists to be able to handle all the fatty liver disease and NASH patients. So how are we gonna make sure everybody gets the care that they need?
Well, it's before transplant or after transplant. I know, Kim, you can talk. How many doctors do you see?
After transplant, I have a gastroenterologist. I just acquired a nephrologist, a cardiologist, and primary care. That's what I'm down to. And at the beginning, I actually had an oncologist. I got rid of him pretty quick. So several, to say the least.
So I agree. She has a lot, and fatty liver patients tend to have a lot. Sometimes, especially if they have more advanced disease, the platelet count will fall. And that's usually one of those pre-test markers that there's cirrhosis brewing in the background. And what will end up happening is they'll go see the hematologist because the primary care will say, well, you have low platelets, so go see a hematologist, and the hematologist will do their thing and all these blood tests and bone marrow biopsies.
Bone marrow biopsy.
Oh my.
And
Got all the biopsies.
all of that. And then find the patient doesn't have a bone marrow or a blood disorder, that they actually do have cirrhosis. So they may see quite a few doctors before they get to us.
Okay, so we have our last, we're wrapping up here. So Kim, I'll take the last word, but Kim, I'll give you the almost last word. What would you want people to know and do for NASH patients?
The medical community, I wish that you would give more education, take fatty liver more seriously than I hear you do. I hear from all kinds of people saying that they find out they have fatty liver and they're told just to go home and lose weight. I wish they would be told, hey, maybe we can get you a dietitian, maybe you can talk to someone else about this and not just send them off on their own. People that are beyond fatty liver, that like me, I was actually told the night I was diagnosed that I would die in 2 years. I was given a death sentence the same night I was diagnosed with
And Kim, we're so
end-stage.
glad that that was not the case. And we want to thank everybody here. Go to globalliver.org for more information.